Hello everyone, welcome to Dialogue web series. So in this video we are going to really see a very important practical point which all of us read these reports in our day-to-day practice. Every alternate patient something we are going to read this NT report, or along with the scan report you are going to get a screening report. So there always been doubts on how to read a first trimester or a second trimester screening report, and how to make it easy and simple so that the next time you see a screening report in your hand, let it be from any lab, you can actually analyze the parameters so that it becomes very easy for you to talk to the patient. Because when a screening report comes abnormal, the instant question from patients would be, why did it go wrong? Did I do something wrong? Is something wrong with my baby? Why did my screen result come positive or high risk? So in this video we will quickly go through how do we read about our biochemical markers, or how do we read our patient's first trimester or second trimester screening report. As always, let's start with a case history. A primary gravida, absolutely normal scan, 25 years old. If you can see over here, in any biochemical parameters or a report, the first thing apart from the routine patient history point of view, where you need to definitely document the patient date of birth, not age, date of birth, to the LMP, mode of conception, and if it is IVF, either the embryo transfer date or the blastocyst transfer date. So these, along with this, a very significant history of a medical history, either with a chromosomally abnormal baby prior, or any significant history or like diabetes, hypertension, also makes a huge difference. Apart from all this, another factor which makes a huge difference is the BMI of the mother. When you make sure that your staffs are trained, if not for us, we can't always, we might not find time to write all this down in the patient lab form, but please do take few minutes of your time to train your staff. If at all your place has a lab collection area and you are collecting blood samples for first trimester or second trimester screening report, educate your staffs outside, the front office staff, to make sure that they record all the significant details. And if they identify something which is abnormal and the patient has a significant history, you make sure that you double check the values, because we have had multiple times that the blood test parameters change, because the patient would think it was a query Downs baby last time we aborted. But if you go through directly into history, you will say that they had probably suspected a Downs baby. Probably they had a FTS which was high risk, say 1:50 or 1:100, and they terminated without confirming whether it was Downs or not. They never did a CVS or an amniocentesis or even an NIPT. So just because it was query Downs or screening Downs, you cannot put the significant history as a previous baby with Downs, because that actually changes your a priori risk in a complete different way. What do I mean by a priori risk? Coming to the FTA screen report, age risk or a priori risk, what you see over here in our screening report is, we do see only 3 chromosomes. So most of the common 3 chromosomes, trisomy 21, 13 and 18. And if you see, the a priori risk over here is the age risk, but the a priori risk can change based on your significant history. If you have a baby with previous Downs and you took it in your lab form, this risk can show up as a red mark, or 1:, say 140 and 150. So here the age risk for a 25-year-old mother would be 1,300 to 1,400. So that's the baseline risk which we see at lab parameters. So then what do we see over here? Like this is the, if you can see over here, there are 2 parameters all of us know. It's a HCG and PAPE, apart from NT and nasal bone. So free beta HCG, what do I mean by DBS, is called dried blood spot, the way we collect the sample. Sometimes most of us, we were doing venous sample earlier. Now we have switched over for many years. Now we do a dried blood spot, because that's number one, the easiness of collecting the sample. You don't need a trained phlebotomist or a trained nurse to collect a dried blood spot. It is as easy as doing a home glucose monitoring. Number one. Number two, the transportation is very easy with dried blood spot. Even if you're during COVID times, where the labs could not come frequently to collect the samples, the dried blood spot actually made it very helpful for us, because the tampering with the DBS samples are very, very less. Unlikely when compared to venous samples, because venous samples, if you keep it in a environment which is not suitable, if you don't refrigerate them, or if your refrigerator is not running, it broke down because of a current failure, then your samples can get lysed, and the lab can actually request for a repeat sample. So remember that either if you have a possibility of having DBS, nothing like it, because both the samples, both the venous sample and DBS, the valuation will be the same, so your parameters won't change. So the observed value is this. We don't have to go into the observed value because that's the direct value, but then when you come closer to the corrected MOM, so what is MOM? MOM is nothing but multiple of median. So when you come to multiple of medians, in all our schools we would have learned what is median. Median is the middle number. So when we come as median, when we come into the correction factor median, the normal value comes as 1. So for any MOM, doesn't matter whether it's a screening report or any report, if you see as MOM, the normal value should be in and around 1. So anywhere between 0.5 to 1.5 is normal. So that number anywhere closer to 1 is perfectly fine. Here if you can see, beta HCG MOM is obviously borderline, it's around 0.55, but your PAPE is very less, it's less than 0.5, so which is 0.2, whereas 1.3 the NT is normal, 1.4 which is closer to 1.5 but still within the normal range. Here your risk is screen negative. So the next time when you read a biochemical report, remember that you need to make sure that you read the MOM value closer to 1. So anywhere between 0.5 to 1.5 is acceptable. So this patient is second gravida. Let's see her previous normal child. So let's see her parameters. If you can see here, both are borderline. Say this is 0.39 and 0.4. Both HCG and PAPE are borderline. But you can see over here that all the parameters of the screen is negative, very well screen negative or low risk. So the reason why we need to know this, because when patients ask, or even for us, if we have to find out why did this turn out, she is only 27 years old, why did this turn out to be screen positive? If you see a high HCG and a low PAPE, that's more suggestive of Down syndrome screening. But over here, if you see 39-year-old second gravida, here you know, so what I was mentioning about the parameters which you have to enter: date of birth, weight. Then you can also, you do have very important thing, bleeding, spotting, and patient is on injection or not. That's very, very important. We do give them height and BMI also. Apart from the age, the LMP, number of fetuses, and all the significant history. Here if you could see, we have ticked gestational diabetes as one of them, because all this carries a huge difference in your a priori risk. And a priori risk over here, can you see here, 39 years, so the age risk is high, it's all in red mark. But here if you see, your HCG and PAPE value are very, very low. As I previously said, for Down syndrome, high HCG and low PAPE points more in favor of a Down syndrome risk, whereas all the parameters, all the placental markers are low. That's both HCG and both PAPE levels are low. If you can see here, both trisomy 13 and 18 are at high risk, whereas trisomy 21 is in the intermediate risk. So obviously, it's very important that we analyze this parameter. Even though the fetus is structurally normal, NT is normal, and nasal bone is seen, we should analyze these two factors so that it's easier for us to interpret the report and tell them that this fetus will definitely require an early target scan and followed by an amniocentesis for confirmation. And this case, why I have taken this as a quadruple screening, because quadruple screening also most of the time that's how we do. As I said, for mom, she 23-year-old young, primary gravida, 17-weeker. If you can see over here, can you see the HCG levels are slightly low, whereas the rest of the parameters are fine. So only the HCG levels are low, but that doesn't matter because the final risk for trisomy 21 is absolutely low risk. So the next time when you see a second trimester screening report, make sure that you read the moms. Normal PAPE mom or any mom for that matter, normal moms are 0.5 to 1.5. Both low PAPE and low beta HCG points more in favor of other trisomies like 13 and 18, whereas or even very, very low, very low. What I mean by 0.1, 0.01 moms will point more in favor of a triploidy. And definitely it makes a huge difference when we counsel a couple. So I hope this video was practically useful for you, because you could probably implement it in day-to-day practice. So for more such videos, do watch our upcoming dialogue web series on fetal medicine. And if you have any queries, particular queries, or if you want me to make more videos on short videos videos on fetal medicine topics, do text me, and we'll be more than happy to take them up in our upcoming videos. Until then, take care. See you soon.